Good evening and welcome. I'm Nora Kane. I'm the director of the Stanford Health Library, and it's my pleasure to welcome you here this evening for our third talk in the series on recurrent pregnancy loss, an important subject. Tonight's topic is the emotional journey of recurrent pregnancy loss, what all women, partners, friends, and family need to know. And our speakers are Dr. Ellie Williams and Dr. Ripal Shah. I'm going to introduce Dr. Shah, and then Dr. Williams will begin, and she's going to introduce and tell you a bit about herself. Dr. Shah is a clinical assistant professor in the Department of Psychiatry at Stanford. She completed her training at Duke University, Harvard University, and Stanford University, and now as faculty, she specializes in reproductive psychiatry, lifestyle, and integrative approaches to health and physician wellness. She's board certified in adult psychiatry and addiction medicine, board eligible in weight management, and has completed additional training in evidence-based approaches to integrative medicine and clinical hypnosis. Her areas of interest include PMDD, infertility, anxiety, and ADHD management. She sees patients in the Women's Wellness Clinic at Stanford, where Dr. Ellie Williams has served as medical director for over 20 years. And now I'm going to turn this over to Dr. Williams. Thank you for being with us.
Well, welcome everyone. Yes, I've been in this field for over 20 years. Actually came to Stanford from my residency at Harvard and helped establish the Women's Wellness Clinic. And at that time, the appreciation for the mental health issues associated with fertility journey was really not well understood. And it has been an honor to participate with the Stanford Fertility Clinic and researchers and clinicians for over 25 years. And so I was very pleased tonight that Dr. Shah and I could come and speak with you. And Dr. Shah and I see folks through Stanford. Prior to this historic year, we're actually on site as, quote, the embedded mental health professionals, but we do see people now through Zoom. And tonight we're going to talk about the emotional journey of recurrent pregnancy loss. So the goals for today are to review the mental health issues associated with recurrent pregnancy loss and to review with you what is known about the methods for improving mental health during this difficult journey. We're going to discuss nonpharmacologic methods, including psychotherapy, mindfulness, nutrition, exercise, and acupuncture. And then Dr. Shah and I are both psychiatrists, so we're medical doctors who do give medication if needed in depression and anxiety. So what we want to emphasize is that depression and anxiety are very common during recurrent pregnancy loss. And this talk may in fact be difficult for some people. And we want to acknowledge that and say that we're providing this talk because we really, really want to relate to you all that mental health consequences do trouble people during this journey, that depression and anxiety are not your fault, and that, again, they are a big part of the journey for many people. We also, as reproductive psychiatrists, are aware that hormonal fluctuations after miscarriage can contribute in some women to the risk of more mood changes. And some of those women who may be most at risk would be people who are very sensitive to hormone changes, such as people with premenstrual syndrome. So as we said, this is a sensitive talk, and we are aware that there can be triggers for people. And you may have already experienced this. Some of the triggers that women share with us are pregnancy announcements on social media, TV movies, and other reading materials with plot lines that have to do with fertility. One of the questions we often get is what to do with the baby shower invitation. It can be a very triggering experience. Other families in parks, pregnant women in the store, and then the sonogram photos that one may have prior to the loss. And then I think what really can be difficult is other people complaining about their baby or the sleepless nights when you are the person that so desperately wants to have a healthy baby. So even today's conversation may be triggering. And if it is, we recommend that, you can watch this later, you can take time for yourself. So what do we do about triggers? To recognize that triggers are inconsistent day to day, and they're very individualistic and unpredictable. And by recognizing that something is a trigger for yourself, it takes some of the power away from that trigger. And so, one of the goals tonight is to think about how to manage triggers and manage the difficult emotions that go along with recurrent pregnancy loss. So, one of the ways to do that is to build a safe space around yourself. Once you recognize some of these triggers, one can actually get some control over them, if possible, by making decisions about avoiding them. Obviously, not all triggers can be avoided, but as an example, the baby shower announcement, if you feel that you really cannot participate in that, then that's an example of a trigger that you may make a choice to send a very warm message and a gift, but not necessarily go if you can't go. And then really creating firm boundaries about sharing your information. One of the things that we hear a lot in our practice is people that feel that when others ask them questions, they're often very honest folk who feel that they should tell them what is exactly going on with them. And we know in the fertility journey that that is absolutely not true. There's so little control in fertility journey that actually having some control over what information you want to share, how much information you want to share, that can be extremely health promoting. And then finally, finding others on a similar journey. And Dr. Shah is going to speak at the end about a group that she's starting. And we really have found from our work in this field that support from other women going through the fertility journey and the unique aspects of the recurrent pregnancy loss journey can be really, really helpful. So we have heard more this year from celebrities and other people about the incredible grief associated with miscarriage. And clearly, one miscarriage alone is very traumatic for people. And there's common themes involved in these, such as a sense of profound grief, which many people are surprised by sometimes because many times this is, quote, early on. But that does not take away the grief. And in fact, when we talk about how to help families and friends with people who are going through this, one of the things is never to ask someone how far along were you. That is not a question to ask someone, because if someone is trying to have a baby, that has been an investment for quite a long time in their mind. One of the other things that I want to emphasize as a psychiatrist is the power and presence of anniversary reactions. Many times women or their partners or family do not even realize that these are occurring. And these are a very fundamental part of our brain. We remember at a certain, often unconscious level years later when a loss occurred. And so now in working with people in the practice, we try to remember with them and prepare for these so that people have room to feel new feelings of grief if they do resurface, or take extra good care of themselves. One of the other things that's a common theme of miscarriage is this sense of responsibility. And this can often be very, very idiosyncratic and at times make no sense, but it's our longing to have control over the situation. So some women will say, I shouldn't have eaten a chocolate ice cream cone. There's a longing that could have been the reason. And we know that is not true, but the sense of responsibility that we feel somehow gives us some control, but it can turn upon itself and people can beat themselves up and feel excessively guilty when there's absolutely no reason. And then finally, a need to make sense of the experience. And this is something that is very important for people because this loss is a marker in life. Many people think about their life before and after the loss, and what one makes sense of that is very important for the future narrative. And people really often want to share that with very close friends or with a therapist in a way to try to make sense. I put some stars here because I want to emphasize that recurrent pregnancy loss is even more difficult for women and their partners and their families. And as unfortunately many of you know, when you've had one loss, people will kind of support you and say, oh, well, you know, there'll be more pregnancies. We're all keeping our fingers crossed. When people have gone through one loss and then a second loss, sometimes people feel like they're disengaging from really believing in the future that there will be a positive outcome. And then with that, there is this intense feeling of lack of control, because sometimes in that second pregnancy, women have really gone to extremes to, you know, follow all the advice regarding the amount of exercise, the amount of sleep, and yet there was a loss. There can be a very clear shared sense of loss with a partner, and as if the two people are alone in the world, because so many people don't have recurrent pregnancy loss. I am going to talk in a minute about the partner and the relationship that can ensue with recurrent pregnancy loss, because we do have to keep track of that. And then clearly that sense of injustice, because recurrent pregnancy loss is not as common as miscarriage, and it is extremely, extremely unfair and unjust feeling. And then finally, the sense of social awkwardness that many women feel with miscarriage in general, they feel even more with recurrent miscarriage. So if any of you are feeling these things in your experience of this journey, please know you are not alone. These are feelings that we've heard clinically, and they're feelings that are articulated in research studies, in interviews with couples and women. I did want to say that unfortunately there's very little partner work, and in heterosexual partner work that has been done, only like 3 or 4 studies have been done. And what has come out in these studies is that the partner, the male partner, frequently feels that they must really hold themselves together in order to support their partner. And so frequently they will suppress their feelings and their own needs even, in order to be, quote, be there for the woman who is going through the physical aspects of the loss. And this can be very difficult. I've known male partners who said, you know, I normally play basketball on Tuesday nights, and when after this happened, I just can't do that anymore, or go to book club. I feel too guilty because she's the one that went through this terrible physical loss. And that these are things that need to be talked about and work through together on how to take care of one another and then yourselves as a couple. The men frequently feel extremely helpless, and then the feeling of isolation. Historically, the fertility journey has not included enough partners and in heterosexual couples, men. It's kind of a real new frontier to recognize the pain that the partner feels and to figure out ways to help them. And so that isolation is particularly pronounced for the male partner. We wanted to spend a minute today to clarify for you that, you know, we are psychiatrists. We do treat mood symptoms, mood disorders, major depression, and that is a different experience than actually a grief reaction. Grief reactions, unfortunately, can move into a major depressive episode, but frankly, a grief reaction is expected in many women after a miscarriage. And it should be more self-limited than a mood disorder episode. And while many studies show that women are still grieving many months later, this grief should not lead to significant interference in one's life. We made this Venn diagram to say that they do have overlapping symptoms. When you're grieving, a person will experience depressed mood. They may experience some weight changes initially, either eating more to comfort oneself or eating less. Sleep problems are pronounced early on in grief, but they should taper off over a month or so. And then the helplessness of guilt can occur in both the conditions. What's important, though, is the degree of the helplessness and guilt. In a major depressive episode, women will feel so guilty that they will really have very negative self-critical thoughts and be unable to do other things than perseverate and ruminate about their guilty thoughts. In a major depressive episode, we define that as 2 or more weeks of persistent mood, loss of mood, depressed mood, where a person simply cannot enjoy anything in life. Things that used to bring pleasure do not bring pleasure. We are not surprised at that in the first few weeks after a miscarriage and in a grief reaction, but that should wane over time, and things that brought pleasure should begin to bring pleasure again. And then the really difficult time thinking, people will feel like they have cotton in their brain and may even feel so hopeless that they have thoughts that they would not want to live. So we do want to articulate that we are very aware that this is a risk after recurrent miscarriage, that in the background population of women, we as a group are not immune to the risk for depression in our lifetime. Specifically, about 8% of women at any particular time will be suffering a major depressive episode. But after a miscarriage, that climbs to about 12 to 13%. But as you can see, after a 2 or more episodes and moving into a recurrent miscarriage journey, it can climb as high as 30%. And so we really want to invite you that if you are feeling any of these very intense symptoms that do not get better over time, to speak with your doctor, speak with a mental health professional. And we're going to finish the talk in a few minutes on treatments for these conditions. So as I said, these symptoms and conditions can become a part of the fertility journey. They are not uncommon. Women who have a prior history of depression or anxiety may be at greater risk. And then one thing that we really want to emphasize is that the level of psychosocial support a person is a very moderating factor for depression and anxiety. And strong social support will decrease the risk of developing an ongoing depression. But that's why I made the slide earlier, because I wanted to emphasize this is one of the unique difficulties of recurrent pregnancy loss. Because when we lose other loved ones or go through grief for other reasons, usually there's a lot of societal support for us. Each culture tends to have its own funeral methods, sitting Shiva or wakes. But unfortunately, we're only now beginning to put our arms around how to support women going through miscarriages and recurrent pregnancy loss. So the social support, frankly, has historically not been there. The good news is that there are treatments for these. And so we wanted to begin the talk by letting you know that if you're suffering, these are common feelings and that you are not alone, and to kind of reflect on what triggers are, how to manage triggers, and then reflect on if any of the symptoms have risen to the level where you would like to get some extra support and help from a mental health professional. I'm going to now talk some about the treatments for depression and anxiety. I want to say that the treatments are a new frontier as well. The women's mental health field is just rapidly growing every day, but this space in the mental health field, it has a lot of room to grow. In terms of preserving mental health, we really focused on this year in particular as healthcare providers in the pandemic. And there's sort of some common principles for all of us in terms of preserving mental health when under tremendous stress. And some of the key principles are that one needs to really be mindful about accepting the things that are out of one's own control. And this is probably the hardest thing to do, because so many folks that we meet are so accomplished, so hardworking, so resourceful, And so much of their life, they have been managing by getting control of things. And so this is extremely difficult to do, to sit and in the space that this is something that I can't fully control. So what does one do that? One then needs to commit to the things that one can control. And that's why Dr. Shah and I started with the triggers, because by identifying your triggers, you can begin to identify what you may be able to control. The other thing that's super important is this idea of daily routines. I really can't emphasize enough how much the brain loves routines. Most people love routines, and we don't even realize it. So, one of the specific research outcomes of grief research is that the loss of the routine is what often leads to persistence of grief. Specifically, we're not talking about miscarriage right now, but like the loss of a loved one. What they found is one of the big parts of that is the routine that we had with that loved one. When speaking with women who have been pregnant, they really miss and think about what it was like when they were pregnant, and having the opportunity to talk about that and think about that is important. But then going back to healthy routines that were very helpful before pregnancy, because a lot of people stop doing their usual routines if they've had recurrent pregnancy loss. And Dr. Shah is going to talk some more about some of the nuances of that and the research on exercise and diet. So you want to get back to a routine or set a new routine that is healthy and very, very beneficial for you. We put down detox of the digital. One of the other things that we see is people constantly going on the internet to try to learn and make sense of this loss. And this can have a very negative feedback. It needs to be controlled. People, we encourage them to set timers, for instance, to only do it at a certain time of day and not before they go to bed. So we call that digital detox. And then finally, I know you may have seen this many times now this year, of trying to practice gratitude. And that is obviously an extraordinarily difficult thing to do when you are grieving, and that sense of isolation that we talked about, but really trying to focus on anything that may be going on that you do feel grateful for. And that can then be written down in journals. For some people, the actual act of writing something is very helpful for them for anxiety. And then clearly engaging in anything that you have enjoyed or taking up something new. We call this faking it till you make it in psychiatry. Because when someone's depressed, they don't want to go to their pottery class, but we know that the brain needs you to do that. You just have to keep doing it. And the other thing that can be very helpful that we've found is doing something altruistic. People often, I can't begin to think of the number of people that in this fertility journey begin to do some other kinds of volunteer work and stuff. There's a wonderful national organization, Resolve, that some of the women over time have become part of. So thinking about something altruistic, it can also be very positive. And then Dr. Shah is going to speak about some of these other very evidence-based methods for helping mental health, such as mindfulness and yoga. And then I'm going to talk to you a little bit more about your self-talk. We call holding two truths, recognizing the situation as having both sides of the coin. You could be very mad, for instance, at your coworker, but still really like them a lot. So you can be very, very, very sad about the loss, but there is some truth that there are still some things in your life that are still going okay, and to try to hold those two truths and embrace them. We really can't emphasize enough how people can be supportive, or they can actually contribute to some of the sadness. The partner, as I've said, that's an issue to really understand where they are so that they can be supportive to you, but also find support for themselves. we wrote carefully selected friends and family because one of the things we've seen in our work is that we oftentimes think that someone that's close to us will be particularly helpful, but they may not be able to be. They just may not have the skills or the understanding to be the person to talk to or to rely upon and get support from. And that's okay in this journey. One of the things we talk about in training our residents to do psychotherapy is the idea of both social support, the person that we really are close to, that when we feel worried or upset, we talk to and they can really help us, versus somebody that is more what we call instrumental support. They can help us do things. And sometimes we think the person that can help us do things will be the same person that can help us feel better. And that's not so sometimes. And that's what we call about holding two truths. That's okay. But we have to be careful and thoughtful about who to be around during this time of this journey. And then support groups, as I said, and then therapists, especially therapists who have a particular interest and experience in recurrent pregnancy loss. We've talked about the self-care. I mean, one of the things that we see in this journey is the self-care can sometimes go by the wayside because there is so much self-care involved in the fertility appointments. People define that as their self-care. And it is self-care, but it's more medical care. We're talking about things that kind of can nurture you and be soothing, independent of these medical appointments. So things like having a favorite playlist and keeping it while you go on your walk, taking time off from work if you can. One of the things that comes up for us in clinic is, how many days to take off after a miscarriage. And these are all very individual. For some people, work is a wonderful distraction and way to get their schedule back. For others, they may really not be able to go back to work for a few days or weeks. And then the power of massage and acupuncture in health are profound, and Dr. Shah will talk about that. So I wanted to tell you that when I said that this is a new frontier, the infertility space has unfortunately not gotten the amount of research that other conditions have in women. But the good news is that over the last 2 decades, there have been some very well done studies of the use of mindfulness for improving the mental health of women going through infertility treatment. And this comes out of the work of Dr. Alice Domar. And these studies were of women going through groups like what Dr. Shah is going to be offering, and looking at their anxiety and depression scores before and after the group. And there was significant improvement in quality of life and depression and anxiety. And so we really encourage people to consider doing mindfulness. Some companies offer it, or being part of a group that's more specialized for fertility. We offer, and the community offers, different types of psychotherapy. And I just wanted to, for your health knowledge, give you some information if you're choosing to look for someone to work with. Interpersonal psychotherapy focuses on the grief that you're going through. It's more open and talking about things. And it's not as structured as cognitive behavioral. It focuses the interpersonal on what you want for the future, how to get there. And it's very focused on the people in your life. A lot of the themes that we've talked about tonight would be talked about in an interpersonal psychotherapy session, which is about 20 weeks of weekly visits. In comparison, cognitive behavioral therapy focuses very specifically on the way you're thinking about this journey and the way you talk to yourself. While brief supportive is more very brief and is a very brief couple of sessions to express how you're feeling. It's not so structured as the first two. And then, of course, couples would be helping the couple figure out how they're doing with the journey, how they're communicating about the journey, what are their goals, what are they having trouble with. So there's four main types of psychotherapy that you might consider, as well as acceptance and commitment. Unfortunately, not enough research has been done on these to say one is better than the other. I would say that the first two do have research that they are very helpful for people and improve mood. In fact, the cognitive behavioral was found to be equal to a medication in women who were acutely depressed. This is an example of what one does in cognitive behavioral therapy. One keeps track throughout the day of how they are thinking about themselves and the thoughts that are coming into their mind. So one stops and notices in a situation how they're feeling, that situation has led them to feel poorly. And then they look at the thought that's involved, and then they try to think about how that thought makes them feel, what kind of thought it is, and then try to work within themselves to come up with adaptive thoughts that could then be less distressing and less causing of depression and anxiety. So here would be an example. The situation is you see a friend on Facebook who is pregnant, and then the automatic thought is, for some people, I will never have a baby. Well, what then does one feel? From that thought, one feels incredibly sad and incredibly anxious. And what cognitive behavioral therapy helps you with is learning about the types of thoughts that these can be. All or nothing is the kind of thought that if you don't get one thing, nothing else will ever happen. Catastrophic is that the very worst thing could happen. Fortune telling is predicting the future. You can see that all of these three thoughts, and there's many, many more that you learn in the therapy, can apply to this situation, but let's just choose catastrophic. A more adaptive thought would be that you're actually working with a specialist to do everything that you can. And that's a very different thought than I will never have a baby. And this may seem simplistic and in the midst of grief, how could I ever do that? But studies show that if you really work at this the way you work out at an exercise program, they become easier to have these adaptive thoughts, and the catastrophic thoughts and the all or nothing and the fortune telling are not quite so quick to come to one's mind. So I'm going to kind of let Dr. Shah speak now more about some of the integrative approaches, as Dr. Shah is, as we said, working at integrative as well as in our clinic, and quite the expert here.
Thanks, Dr. Williams. I'm really happy to be here and talk to you about my two passions, which is women's mental health and integrative medicine. In integrative medicine, we study quite a bit the lifestyle modifications and non-pharmaceutical benefits of interventions. And in women's mental health, we study this specifically for reproductive age women. And so I'm excited to kind of give you a little bit of information on what the studies have shown more recently for how these two fields have merged a bit. So there have been several studies on yoga as a treatment for specifically infertility related stress and distress. These are the four markers actually in the most recent study published on which factors of stress are actually able to be benefited by frequent yoga. In this situation, they actually found, in the study, they found that both the amount of stress someone experiences for themselves, the amount of stress they have in their partnership or relationship, how much stress they feel in social settings, as well as how much distress they feel related to fertility, all decreased. Next slide. So for exercise, we kind of call this the Goldilocks phenomenon when it comes to fertility specifically, and that's because both women and men have improved infertility markers when it comes to moderate exercise. And I think one thing we want to emphasize here is while infertility is tied to both too little and too much exercise, what is considered too little and too much really varies by person. And so if you are someone who has run a marathon a day for your entire life, that might not be too much for you, but for someone who is drastically changing their exercise regimen, it might be now might not be the best time to drastically alter it. Most of the studies actually marked the appropriate amount of exercise to be somewhere between 3 to 5 hours a week, and was thought to be a moderate amount of exercise. Men specifically who exercise moderately, which in this study was 3 hours, so 3 separate times of an hour each, scored higher in all sperm parameters that were tested in this study. So every single marker that they were testing improved in the men who exercised moderately compared to men who either exercised too little or too, what the study defined as too intensely. Next slide. Another aspect of exercise that can be useful is its benefits for people who have overweight or obese BMIs, which is essentially improvement in weight loss. Can also improve fertility, and so having being as close to normal weight as possible can actually improve, and exercise obviously improves both of those things. Less than 5 hours a week of exercise, which again is thought to be moderate in most studies, did show in many studies improved fertility, regardless of if the person was underweight, overweight, obese, or normal weight. But we do want to emphasize that exercise plans, as always, should really be discussed with your doctors and fertility specialists first, because there may be certain limitations in treatment regimens. For example, when you're going through treatment, there's specific times of your cycles that aren't appropriate to do intense exercise because of risks of various health consequences that can happen during specific times. For example, right after stimulation, it can be a quite sensitive time for the body. And so just make sure that your physicians are aware of what your exercise plans are and adhere to individual recs that are given by them. Next. I'm going to talk really briefly about nutrition. There's quite a bit of information out there about nutrition, and it can be quite overwhelming, specifically when it comes to fertility foods, or what people would think of as foods that can improve and boost fertility. The main thing I'll talk about today, which is the thing that is most studied, which is anti-inflammatory foods have overlap both with improving fertility as well as mental health. So when we're talking about the intersection of mental health and improvement in fertility, incorporating as many anti-inflammatory foods as possible into one's diet has been shown to be effective in both of these modalities. And particularly, as we mentioned, operating at the intersection of these, there's quite a bit of confusing information out there. There are conflicting studies on most things, but anti-inflammatory foods have been one place in which there's little controversy. I'll show some of the anti-inflammatory foods that have been shown in studies to be effective for both mental health and fertility, and that's particularly having as much of a plant-based emphasis as possible, having as many fresh fruits and vegetables as possible. Antioxidants, that includes berries, leafy greens, beets, avocados, spices that include ginger, turmeric, green tea with as little caffeine as possible, but so not overdoing the green tea, but and I'll talk about that in a bit as well. Omega-3 fatty acids have been helpful, not just for inflammation and for fertility, but has also been shown independently, even in people who are taking supplements for omega-3 fatty acids in depression and anxiety as well, independent of fertility. Diets that are rich in fiber, including beans and lentils and whole grains, are also considered to be anti-inflammatory. The main thing that most of these anti-inflammatory studies show is to avoid, as much as is possible, red kind of fatty meats, processed foods like candies, chips, bags, like things that are highly processed or refined sugars, and then low fat dairy. Most studies recommend high fat dairy, particularly during the fertility journey. This kind of just recaps some of the foods that are included in the study studying anti-inflammatory foods for mental health as well as fertility. I have asterisks next to green tea, grapes, and dark chocolate, with some good news, which is these are called polyphenols, and they're the flavonoid class of foods, and they actually work in a similar place in the brain as many anti-anxiety medications and even some antidepressant medications. And so these, and again, with the green tea, one has to be careful with caffeine intake, but these are foods that are kind of ways to get a very more immediate impact on anxiety because of the way that it works on the brain. And then all of these foods are actually quite helpful for decreasing inflammation in the body. And in summary, essentially, the fertility diet or fertility foods that we're discussing are essentially to avoid certain heavy fats, red meats, low fat dairy, and then to kind of focus on high fat dairy, low glycemic foods, meaning lower refined sugars and and getting more of your carbohydrate intake from fresh fruits and vegetables, and having as much protein from vegetables as possible. I'll talk quickly about acupuncture. I think acupuncture, we do get quite a few questions about acupuncture and its utility, both in mental health and fertility. In some good news, the studies so far on acupuncture have shown benefit for these conditions here. And we've highlighted specifically the intersection again of what we're discussing today, which is stress, anxiety, and depression and infertility. And there are independent studies as well as studies showing that people experiencing both of these can benefit from acupuncture. One of the ways that this is thought to happen is several studies show that acupuncture might be helpful for hormonal regulation and normal menstruation. It may improve the health of the uterus while also decreasing stress in the body, both physical and mental stress in the body, both of which would help fertility. Even several, and I think in this study it was about 3 sessions, even several acupuncture sessions improved the lining of the thickness of the lining of the uterus, reduced stress scores, and improved satisfaction of those going through those sessions. I think one thing we wanted to emphasize a bit, and I'll hand it back to Dr. Williams in a second, is that mental health treatment really works. And I think some of the hopelessness that is experienced throughout this journey is that, what do I do now? What can I do at this point when it feels like nothing is really working? And we want to emphasize that in so many places, this is something that is a place where having the option to have treatments, as individualistic as it may need to be for you, that can be discussed with your physician. Many of our studies show that just intervening is the first step, and having intervention and treatment is the first step to having treatments that work for you.
Yeah, thank you, Dr. Shah. And we really want to emphasize that the treatment of anxiety, depression, and stress in this journey is for you, for the quality of your life. And so in that regard, for some people who are very, very depressed and suffering a great deal, they will ask us whether they should return to taking an antidepressant they may have taken in the past or start one now. And this is beyond the scope of this talk, but the take home is that in the studies that have been done, antidepressants of the common ones that are used now, such as the SSRIs, do not appear to be associated with an increased risk of miscarriage as a class. You may look on the internet and see that they may be associated, but if you look at the rates of miscarriages in those studies, the people not on the antidepressant had incredibly, both groups, lower rates than general population. So people have criticized the study for that reason, because we need to really understand what the differences in the groups were. For instance, were certain risk factors in the people also on antidepressants? Until people do very careful studies like that, we can't say that. And most studies have not shown any increased risk. And in fact, Dr. Lathe's group here at Stanford looked at outcomes of women who were exposed and not exposed with similar backgrounds in terms of age and egg quality, and did not see an increased risk. So it's a very individual decision, but we do know that the treatment of depression is very, very important for the quality of life of the woman, for her health, and also women and their partners drop out of treatment when they get too depressed. And the treatment is what is going to be so crucial for getting further in the journey and hopefully having the success that one so desperately wants. And so we want to emphasize in summarizing that, this is a very, very difficult journey. You know that already. But we want to reach out to you and say, as people who are trained in psychiatry, we really see this. This is why we have focused on helping, because many studies show that people going through this have high rates of mental health concerns, similar to any other medical condition that is being seen in the hospital. And so one needs to be open to the many different treatments that are available, both non-pharmacologic and pharmacologic. And then we want to emphasize again that there's, as this series has shown, many, many medical advances that are coming forward, that Dr. Lathy and the whole team at Stanford Fertility have been working so hard on. And you are not alone in your mental health concerns. We want to be helpful with that and partner with the fertility team. We have colleagues in the community that see people as well and can help steer you that way too. And I'll stop for 1 second and thank you for listening. And Dr. Shah will tell you a little bit about the group that's going to start.
Yeah, thanks. So our clinic, the Women's Wellness Clinic, is actually starting an infertility group, an infertility mental health group starting next Wednesday. We're actually starting just with 3 sessions, but hope that with enough interest, we'll be able to continue this as a weekly support group for those going through this journey. If you're interested in registering, just please feel free to leave a message at the number at the bottom of the slide. It is held via Zoom. There's at this point, it won't be done in person, will be done virtually. And we'd be more than happy to have as many of you as are interested in being in a support space like this. I will start each group going over some of the exercise and nutrition benefits we've talked about, and then we'll open up the space for processing. And so please feel free to sign up if you're interested. So we have some questions in the Q&A. I'll say quite generally, in regards to questions about diagnosis and treatment, we really strongly recommend discussing those with your physician directly, because there may be a lot of nuances that in a general setting we may not be aware of. But maybe we can start off by talking about some of the questions that are more general in regards to our talk and in regards to what the options might be from here. I'll start off with answering a question we received about whether or not there are support options for partners of people experiencing RPL, and essentially, I'm assuming the question is more so for male partners. The answer is essentially right now, many of the groups that are available are particularly for women having experienced miscarriage. That being said, if we do have enough interest in that space, we will extend it out to have one of our providers in our clinic also be able to offer support groups for partners. And so essentially the answer is the more interest we get in this, the more likely we will be to be able to offer that.
One of the questions is depression after a miscarriage typically considered postpartum depression, or are there different diagnostic criteria for that? That is a really good question. And I want to state that in general, no, it is not defined as a postpartum depression. If a person does deliver a child at term or early, let's say 24 weeks, then it could be defined as that if there's a loss. But a miscarriage prior to that generally is not considered a postpartum depression. That doesn't take it away, though, in any way that a person would become depressed. We would just define it as a major depressive episode, but not put a postpartum qualifier on it.
I'll answer a question about acupuncture, a very good question about acupuncture, which is at the first RPL session, it sounds like there was a discussion on limited data on the benefits of acupuncture and infertility in general, but that may help secondarily via stress reduction. So essentially the studies that we look at specifically are in people experiencing both infertility and mental health treatments. And in those populations, there has been more live births in people who have done acupuncture treatment. And so I'll defer to the REI experts on specifically acupuncture and infertility as alone, but in the studies that discuss acupuncture in treating infertility and mental health, it has been shown to have benefits, and it may be due to the secondary stress reduction.
There's a question here: are there any studies done on secondary infertility and recurring miscarriages? That is how women with one or more children cope when they have recurring miscarriages after having a child. Guilt feels particularly strong. I should feel lucky. I'm not the mom I would have been. I'm too focused on fertility. I am, first off, it's hard when you're all asking such important questions. Um, I just want to acknowledge that each question has suffering behind it. So this is a very, very important question because we see this in our clinic. Women who have had a baby who then go on to have a miscarriage and recurrent miscarriage really do often feel that they should not be grieving. And frankly, they can get some pressure from other people that way, family and friends. And research has shown that women who already have a child do grieve intensely. And in some studies, they're equal in the rates of anxiety and depression. Some studies, a recent study that we had up about partners, interviewed recurrent pregnancy loss couples and looked at risk factors as well as gave the opportunity for for depression and anxiety, the couples to speak to the fertility specialists and the researchers about their experience. In that study, having a child decreased the depression, but there are many studies that show that it's as intense. And so I really want to emphasize that that is a very lonely space, even when one has a child, because one feels guilty. I think the answer to the question is being really mindful, really deliberate about taking the time with the child that you do have, because grief can really take over one's life. And that's an example of fake it till you make it. Go to the baseball game, go to the musical things, even if you don't feel like it.
We also had a question on the yoga slide on if there were any information in that study on frequency or amount. So that study specifically was on stress indicators for women experiencing infertility. And they did have the participants do yoga twice a week, I believe for 60 minutes for 6 weeks. And so it was twice a week for 6 weeks. And after those 6 weeks, they saw improvement in those stress scores. I will say when I give a yoga prescription to my patients, I usually advise there to be a 90 minutes allocated if possible. So effectively a 15-minute meditative startup, the 60-minute class or group or video or however way they're doing their yoga practice, or it could be independent. And then a 15-minute meditative downplay, because it's kind of a way to also get 30 minutes of meditation, which has also been shown to be beneficial for mental health, namely anxiety. And so essentially the study said twice a week for 6 weeks, and I often recommend sandwiching it with meditation as well.
There was a question, is there any difference in the intensity of grieving between early and late pregnancy loss, single versus multiple? That is why I said earlier about not asking someone where they were. This is a good question because specifically many people assume that if it's an early loss, the woman or their partner is not as attached. That is actually not true. Clearly the trauma physically of a late miscarriage is very profound. But as I would say that for so many people, the intention to create life and have a baby is the very beginning of the attachment. And so we have seen people very depressed after very, very early losses. And some people, we wanted to emphasize the importance of risk factors for anxiety and depression. Does it run in your family? Have you had them before? For also making the risk greater for the very difficult grief, because some folks are more vulnerable under times of extraordinary stress, and this is an extraordinary stress.
We also have a question about caffeine intake and decaf coffee versus getting rid of it altogether. It's a very good question. I think in regards to caffeine and fertility, I'll defer to the experts in REI on that. In regards to caffeine and mental health, I can speak to that a bit, which is most studies for mental health have shown that caffeine can contribute to increased anxiety, but also discontinuing abruptly can cause mental health consequences. And so we normally recommend not decreasing more than 25% at a time. And at a time, we mean, I usually say 2 weeks to my patients of how much they would want to decrease, to try to get to about one average cup of coffee a day, 100 to 200 milligrams. And we really recommend not going much above that, or doing it at varied times of day, particularly in the afternoon, just because of its role in anxiety and possible sleep disturbances. In terms of decaf coffee, it's a very good question. There are several rare studies, I should say, about the coffee bean itself being a functional food for mental health, meaning that there may be something we're deriving from the coffee bean that's outside of the caffeine that could be beneficial for mental health. And so there aren't any studies to say otherwise about decaf coffee, but there are some studies describing caffeine as being detrimental, particularly for people experiencing anxiety.
There was a question, so there's a couple very specific questions, for instance, about lamotrigine and EMDR, and I think we would recommend that you speak with your providers about that. You know, I don't think that's something that we would talk about in general here. But one of the questions, a couple of questions about disability, again, that's a very individual question and answer. You know, one needs to, it's just such an individual question. For some people, the loss can trigger a pre-existing condition, both medical or psychiatric, and the disability would be a very different situation. They may need to go to a treatment program, an inpatient or outpatient, you know, in which case they would really need, you know, a lot of time off work. Each person's workplace is very different. When we've been asked to be counseling people on this, we really have to spend time thinking, you know, what are the risks and benefits of doing this? For some people, cutting down on their work is the best way to go in this economic times. So I can't really answer it so specifically, but I do want to acknowledge that the whole fertility journey is a huge stress on women and their partners in the workplace. And I do have a positive thing to say, that I do think companies are getting more interested, because last year, Ariana Huffington's Thrive Global asked us to do a series of workshops for managers in companies to try to teach them what everyone is going through in the fertility journey. So it's not necessarily going to help you today, but I do think things will begin to get better. That was sort of dovetails with the guilt of the work stress. You know, I think that's where the cognitive behavioral can come in, because so often people who are really wonderful workers are also the very people that beat themselves up the most about their performance when they're undergoing something like this. We can't do everything. If you're having a miscarriage and you're grieving, you know, it may be that you just need to do, you know, less at work if you can, if you're not going to get fired, or if you need to take some time. These are very individual decisions, but recognizing that this is very real and other people are in the same place.
I'll briefly touch on the question about herbal medicine, mostly to say that they're often not well studied, and the reason for that is the chemical nature can really vary from some medicine compounds to herbal medicine compounds to others. I think the most important thing I can say for this is, if you take anything, supplement, herbal medicine, or all, make sure your doctors are aware, because there are quite a bit of contraindications to several other medications that your doctor may be able to offer you, as well as it not being so friendly with both fertility medications as well as mental health medications. And so it's just important for your doctor to know if you do choose to take herbal medicines. But in terms of kind of the data along those, there's just not much, since it's not easy to isolate different compounds specifically because of the nature of how herbal medicines work. But the main emphasis is, if you do try something, whether that's supplement, vitamins, herbal medicines, please make sure that your doctor is aware of anything you're taking that's not already available to them in your chart or pharmacy.
There were two kind of general questions that I think we could finish with. One was, can you please speak to cortisol levels in pregnancy, the fear of how it will damage the baby tends to lead to more anxiety. This is a very complicated answer because the bottom line is that pregnancy alone is a state in which the body has elevated cortisol, and each person manages cortisol in a different way through proteins created by the liver. They have searched to show that higher cortisol causes all these problems. It's not so simple. The take home is, when you think that thought, remember that people have babies, in war. We have people up on the ward that have babies that are unbelievably stressed. So it's not so simple. The take home, though, is to really engage in the things that Dr. Shah and I are talking about to improve your quality of life, which will then be important for stress levels. We don't want folks to be saying, oh no, I feel anxious, so therefore I'm going to, ruin this pregnancy, because that is really not fully determined. And many people who are very, very stressed do have healthy, term pregnancies. So, and that then brings to the other question about, if you've had a lifelong history of depression, is it kind of guaranteed you're going to be depressed in pregnancy? No, we know that people are more at risk, but again, this is a very individual finding, and it would be something to sit down with your psychiatrist or a specialist on the risks and benefits of staying on medication if you've had multiple episodes of depression. Well, I think that concludes our program. We're so glad that we could spend time with you all. And someone asked about coming to Women's Wellness. There is, Dr. Lottie's group will have a phone number. We are unfortunately not enough of us and many people in need. So we may not be able to see you right away, but we can also help find people in the community too that can see you.
Thanks everyone for coming.
Bye-bye.